Hi, we're going to be continuing with the interview with Dr. Gaby today, and we're going to talk about primarily two things. Something pretty controversial and something that everybody asks each other, whether they're a physician, a healthcare practitioner that really wants to get into the meat and potatoes of understanding their patient or their client. So one is we're going to talk about DHEA, which is a steroid, which is pretty much a surrogate for testosterone for many men. I'm not going to say anything more than that because we're going to use this here in terms of medical nutrition, in terms of a special class of people. Who needs to use this? And what have the results been? Interesting conversation coming up. And the other is we're going to talk about labs, the labs that we all use. And I think you're going to be surprised. I was surprised when I talked to Dr. Gaby, finding out the labs that he did use. So coming up, hope you enjoy it. I'd like to go into DHEA, and then let me give you a little context. I remember, being a student in every class, and you're just salivating for, when I get out, I'm going to try all these things. When I get out, I hope I go to a state that has IV, which I didn't. But so much for that fantasy. But the other stuff, so DHEA was one of them. It was like one of these miraculous things. Not that anybody, it was with great caution. The other was, I'll get to that later, maybe. But let's go into DHEA a little bit. I used it some. I have mixed results. I'm more cautious now than I probably was before. I'd love to hear what you have to say with it. I mean, you have a great chapter on it.
Yeah, well, DHEA is a steroid hormone, and it is produced naturally in the adrenal glands. In males, it's produced in the testes. So about 50% is produced there and 50% in the adrenals. In females, it's produced, we think it's produced, pretty sure, in the ovaries, but only about 10% of the DHEA in females comes from the ovaries, and the other 90% comes from the adrenals. At menopause, that little bit extra produced by the ovaries seems to make a difference, because sometimes when we give DHEA as a supplement, it relieves some of the menopausal symptoms, and it also, in a few cases that I've seen, reversed some postmenopausal bone loss. The main area that I use it, aside from autoimmune diseases, that's actually in the regular medical literature. You can treat lupus with high dose DHEA, and there's some evidence you can treat rheumatoid arthritis or related conditions. But the most common is when I see very old people or moderately old people who are playing their life very old. They're fading more rapidly than they should. We used to call it the dwindles. They're losing weight, they're losing muscle mass, their mind is going, their appetite is going, their mood is going. I remember an 80-year-old woman came in. I don't know why she came in, but she was depressed, and all she could talk about was whether her will had been filled out properly. And so I measured her level, serum DHEA, measured as the DHEA sulfate, because that's easier to measure. There's a lot more of that in the bloodstream. And I typically compare it to the level in a young, healthy adult, because we know it declines with age. And the question is whether the decline is a normal age-related factor, or whether it's related to some of the things that happen to us as we get older. So if the level is below normal for a young, healthy adult of the same gender, you have to compare, because men have much higher levels than women. But if it's low compared with young adults of the same gender, I will always consider a low dose supplement. Now, for me, low dose is 5 to 15 milligrams a day in women, 10 to 20 milligrams a day in men. And that's a lot lower. They use typically 50 milligrams a day in research studies. And that's more than the body makes. And when you're dealing with a steroid hormone, I don't think you want to be, in most cases, giving more than the body makes. But anyway, so I put this woman, I can't remember, it was either 5 or 10 milligrams a day. And she came back 6 weeks later, and she had joined the fitness club, and she had signed up for Carnival Cruise, and she was happy as a lark, and wasn't talking about her will. Another patient, I never actually saw this patient. It was actually the father of one of the naturopathic students, who I think was in your class. And she said to me, my dad is 87 and he's really going downhill, and it's really terrible in all ways. He's just losing it. And I didn't have access to measuring his level, but I just assumed low dose DHEA is reasonably safe. I said, well, just give it a try. Put him on 10 milligrams a day for a couple months, see if it makes a difference. And a few months later, she said his life turned around completely. He put on muscle mass, his mood is better, his energy level, the whole thing. So it doesn't work for everybody. I've tried it on some older people who had low levels, and I gave it to them and didn't do any good. But it's happened enough, and the results were so profound that I think it's worth looking at. And again, steroid hormone, get medical supervision with it. This, even though it is sold over the counter,
Right.
I think it shouldn't be. I think steroid hormones, they tend to be abused by bodybuilders, and some people, very high doses might cause prostate cancer. So, but I think it's a very useful thing for a subset of the population, and it should be a part of standard medical care, in my opinion.
I appreciate that. You mentioned serum levels, and you're always skeptical of using labs, generally speaking. How is serum and relative to maybe urine? I'm thinking of the Dutch test, and that's one of the things that they measure. Do you sort of say, we're just apples and oranges? I wouldn't even mention them in the same sentence.
Yeah, well, neither of them has been confirmed as a reliable predictor of who's going to benefit and who's going to be able to take it safely. I don't see any problem with checking the urine. If you do a 24-hour urine test, that gives you a fairly broad indication of how much is being made in the body, because that's how much is being excreted. So I think either of those would be reasonable. And I would also say that neither of them is entirely reliable, but it's probably a little bit better than guessing.
Yeah, no, context is everything. Belt and suspenders is a good way for sure. I'd like to get into labs in particular. We mentioned it in our correspondence. Tell me where you are in labs. Kind of said, I wonder what labs, that's another, I wonder what Dr. Gaby would think. It's like, what labs does he take? And you said, well, actually, I don't take that many labs, just sort of the basic amount of labs that most people take. Please.
Yeah, I mean, you want to do the complete blood count. You want to do the chemistry panel. You want to know what iron status is. You want to know what thyroid function, liver, kidney, et cetera. And that is what any family doctor or internal medicine doctor would do. There are a wide range of so-called alternative labs, and I have not been convinced. I've researched some of them and have been convinced that they're unreliable. There are others that I've not seen any evidence that they are reliable. So in general, and then you get hassled by insurance companies for running these labs. So in general, I don't think it would change my my clinical judgment on most cases on how to treat them or what recommendations to make, because I haven't seen any of those. That now, stool analysis, maybe you might find something there sometimes if you culture it, but you can also be misled. Dr. Leo Galland about 30 years ago did a study where they cultured for yeast, Candida albicans. And what he found was, and then he treated people with antifungal drugs. And he found that having a positive stool culture for Candida was a better predictor that the antifungal drug would not help them. Having a negative stool culture for Candida combined with a positive, he would go in and scrape the rectal tissue and he would look at it under the microscope. And if he saw a certain type of the hyphae, they call it, if he saw those from the yeast in the cells, and they had a negative stool culture, that was the best predictor that they needed antifungal drugs. So nobody tells you that. And even that wasn't 100% positive. What he found was that when you are suffering from Candida, your body is fighting it and your body is producing an inhibitor, and it's excreting that inhibitor into the bowel. And therefore you can't culture it. You can't culture Candida because your body's blocking the culture. So there are, and then there's this other thing, the caffeine clearance test. I don't know if anybody's using that anymore. It was designed to determine how well your body can detoxify things. So they saw how you metabolized caffeine, which is fine, but caffeine metabolism is only one of the 57 detoxification pathways. So that doesn't tell you anything about the other 56. And then there's the neurotransmitters. They do urinary neurotransmitters, and they purport to tell you what herbs and other supplements you need to take. But the problem is these neurotransmitters do not cross the blood-brain barrier. So what's going on in the outside of the brain may be totally different from what's going on inside the brain, and you therefore can't come up with any conclusions about what they need. So what they did is they had 4 different types of treatment protocols, and everybody got better. But the problem is the treatment protocols are helpful for people, and it didn't really demonstrate that basing the treatment protocol on the test produced any better results than just randomly throwing a dart at the wall and trying one of the treatment protocols. Same thing for blood type diet. All the blood type diets take everybody off of sugar. 3 of the 4 diets take people off of wheat. One of them takes them off of dairy. One takes them off of corn, which are all very common allergens. So statistically speaking, a lot of people are going to get better if you do want any one of the 4 blood type diets, but that doesn't prove that a specific blood type has to do a specific thing. So basically, I do a good history. You got to talk to people. There's no substitute for asking as many questions as you can. I'll give you an example. This whole thing about thyroid, I think a lot of people have what I call sub-laboratory hypothyroidism. It's subtle. It doesn't show up in the blood tests, but they have multiple symptoms. And you do a physical exam, their Achilles tendon reflex comes back very slowly when you hit it. It's supposed to come back like that. It comes back like that. And that's a classic sign of low thyroid. You do what they call an empirical trial of thyroid, which is an educated guess. You give them thyroid hormone, and all these symptoms get better. And they do it safely, and their cholesterol comes down, their blood pressure, all this stuff. And if I had to look at the 50 greatest responses I had in my medical practice, at least a fifth of them would have been thyroid hormone therapy in people who had normal blood tests. But anyway, now I forgot why I brought this up.
we're on labs. Go on any tangent you want to follow. We're on labs in general and saying how it wasn't a close correlation a lot of times.
Yeah, so that's another one. But there was something else. It may come back what I was trying to say. But
okay, I have a tangent to go on too, and that is that the other thing that I think of Alan's class was the elimination diets in your book as well. And I was so impressed with that. I go, wow, here's a guy who knows all about all these other things. And yet he's talking about the elimination diet, really hands-on diet. So I got called up on the carpet because I worked for a group initially and I went my own practice, and that I wasn't prescribing as much supplements as they were hoping that I would for the profit of the group. And I said, well, I'm focusing on, ask everybody for a 7-day diet diary. And then we look on it and I look for wheat and dairy, and I take away, the allergy elimination diet. And there wasn't any need for supplements after that relative to their chief complaint. And so it's like, that is so underused. That was so powerful that it was like, now looking back, of everybody I've ever seen, regardless of chief complaint, I would say, get them off dairy and wheat, or am I talking gluten and casein? Pretty much the same thing. You would have half the symptomology of any given case and maybe remove it completely. I just thought I'd insert that because
well,
go ahead.
One of my medical school professors, he was very well known. He was highly respected. He wrote a couple of the chapters on infectious diseases in Harrison's internal medicine textbook. He was straight conventional medicine, but he was so wise. And one of the things he said was, the better trained you are, the fewer tests you will need to order and the fewer medicines you will need to prescribe. So I will honor what you just said, because you identified the cause. Mm-hmm. The cause in this case was a specific allergen in the diet. Not only did you identify the cause and save the patient money, but you also allowed them to take control of their health.
Yeah.
Which, if you're giving them a bunch of supplements, they got to keep coming back and getting reevaluated and all that stuff. So that's good medicine. So I appreciate that you're doing that. I do remember what I was talking about now, because I said you have to do a very good medical history. So normally there's this thing they call the review of systems. There's this huge checklist. You go down the list and you hope they all answer no for every one of them, because that saves you a lot of time and effort. And you put at the bottom, review of systems, non-contributory. That's what they taught us to do when we wrote up the case. Anyway, the review of systems can often be very contributory if you don't rush through it. And the example that I like to give, I was at a retreat with a bunch of medical students who were trying to learn holistic medicine. And there was a 24-year-old woman, medical student, and she was my guinea pig. I did a history on her. And I said, do you have fatigue? And she said, no. I said, how many hours a night do you sleep? She said, 10. I said, 10, that's a lot of hours. What happens if you sleep less? She says, oh, I'm exhausted. And then I said, do you have constipation? And She said, no. I said, do you consume a fiber supplement or eat a high fiber diet? She says, yeah, I take a fiber supplement. I said, what happens if you don't? She says, oh, I can't go to the bathroom. And then finally I said, do you have dry skin? And she said, no. And I said, do you use any moisturizing cream? And she said, yes. And I said, what happens if you don't? She says, oh, my skin is really dry. So this was an amazing example of you do the first round of testing, of questioning, and you get all negative answers and you just proceed to the next thing. So by doing the additional follow-up, I was able to identify 3 very subtle, but possibly important clinical aspects in her case. And when I checked her Achilles tendon reflexes, they were delayed. So here was a case of hypothyroidism that would never show up on blood test. It would never even show up by her, quote, chief complaints. But she had it, and I didn't give her thyroid because this was just a demonstration. But there are so many people who have symptoms that they don't even think of anymore. There was one woman who came in because of recurrent infections. And I asked her if she's tired or depressed and things like that. She said, no. And I didn't follow it up. But I put her on thyroid hormone for various reasons. And the chief complaint of recurrent infections, that cleared up. But when she came back, she was so happy. She said, you asked me if I had fatigue and depression. And I said, no, because I didn't know what it was like to feel other than the way I did. My life is so gloriously happy now.
You know, you talk about iron, not a lot, but it comes talked about your dad with Dr. Perlmutter's interview. And I think it is so underutilized both as a test. It's almost like the boring part of labs. You obviously do iron, but you do ferritin and saturation and TIBC and so on. Pretty standard. Do you value one portion of that over the other? I mean, do you sort of say it's, if you have normal iron, low ferritin, do you sort of say, well, we're kind of functioning, but the boat's getting pretty empty here?
Well, I described how to evaluate lab tests, iron tests in detail in the textbook in my chapter on iron. And I reserve the right at my age to forget anything that I've written down. However, what I will tell you is that none of the tests are always reliable, because ferritin, for example, rises in response to inflammation. Percent transferrin saturation is affected by other factors, which I don't remember, but it's well known. So what I usually do is, if I'm really worried about iron deficiency, I'll measure them both. And I'll take inflammation into account. I'll take whatever other factors I read in my book that you have to look at. Yeah. But yeah, in general, I like to do them both because you can get a better idea of that. The best test is a bone marrow biopsy, and nobody's going to be doing that. That's the most reliable. And you try to find lab tests that correlate best.
Well, did you get as much out of that interview as I did? And that's just one small little piece of it. I had to break it down because when you talk to Dr. Gaby, it is pretty condensed information. It's like having a very rich meal. So if you take it in slices, it's better to digest that way. I've always felt that as being a student, and certainly as you're applying it clinically. But what I wanted to talk about is that we mentioned about DHEA. Well, DHEA is used for a lot of bodybuilders, you said. So it's a steroid. So it has the good and the bad of the same thing as most steroids. It's not that all bodybuilders do it. It's out there. And unfortunately, because it's an over-the-counter, you can get it at Walmart probably in terms of their supplements. I don't know about DHEA, but you can get it pretty available for a lot of people. And it really shouldn't be, because it is a steroid. So moving away from that, and those people are using what they call superphysiologic doses. Those are using doses that are higher than they should have. They're amping up their levels in their body. That's not what I'm talking about, and that's not what Dr. Gaby was talking about. He's saying using just a little bit after you've seen and tested that maybe there's a reason that this could be effective for this particular person. So I happen to have a case to show you what does urine testing look like, and then what does serum testing look like. So this is a Dutch test. Dutch is a dried urine, comprehensive urine hormone panel. And it's a 24-hour, more or less it's a 24-hour urine sample. So why do we use that? Because we get to see output. What is a 24-hour output of this particular person? So in this case, we're seeing that this happens to be a post-menopausal woman. Look at her DHEA. her DHEA is colossally low. So here's the age. You can say, well, over 60, it should be 500 to 1200 of these particular units of all the metabolites. These are all the metabolites of DHEA. We're going to go into a little detail here. I just think that you should see this. Is it way under? So on urine tests, 24-hour urine test, total production of the adrenal gland to make DHEA is pretty darn low. Okay, let's go a little further. These are just, we're not going to get into that so much. Here again, we have a little larger perspective of DHEA-S. We're going to look at that in serum in a second, but DHEA sulfate is what you measure in serum. That's a blood test. Also, you can find it in urine. So we're having an overlap. I love when two tests test the same thing in two different mediums, two different tissues, if you will. So here, again, very low. The range is 20 to 750 of DHEA-S sulfate, and it's 10. Again, it's a verifying measurement per urine test that it's a very low, the adrenal gland's very low in terms of this. Where else are we going to look at? Here's a little more of a visual. Here again is all the metabolites that this person is producing and how low they are. This also corresponds to their cortisol output. So here's DHEA from the adrenal gland, and cortisol and cortisone is the inactive form. I'm not going to get into that, but I just want to show you we now have a verifiable low via urine test, both in terms of DHEA metabolites and DHEA sulfite. Okay, so now let's go to the a serum test and let's actually see in serum if it corresponds. It's kind of a belt and suspenders approach, if you will. Conservative, but accurate. Okay, here we have the results, what the results look like in DHEA-S. So here's the range, and the range is, supposedly the range is 7 to 177. 7 is down here to 177. This person came in at 40. So what does that mean? They're in the lowest 8% of the range that they should be having. So obviously this person is living still, but very, very low. It's being underproduced. Back to the discussion with Dr. Gaby, it's being underproduced, and maybe a little bit, we're not talking super physiological doses at all, maybe a little bit will make a big difference. This is how we verify that decision, the decision to try a person out on this particular steroid. Might even help testosterone. Certainly would help men much more effectively, but it also helps women in that regards too. I thought you should know. I wanted to explore Dr. Gaby's website. You know, would have been easy just to simply say, oh heck, let's go and let me get back, go to his website. The link will be in the show notes, but I think it's better to show you. Here is what his book is. And so it's quite the tome, as you can say, quite the tome. It takes 2 hands to pick it up. It's a good 9-pound book. He thinks it's 8 1/4. It's a 9-pound book. And why am I going so far to even represent this? I have no financial interest with him. Dr. Gaby got nothing out of being on the show. I didn't pay him anything, and vice versa. I don't have an affiliate link to this. Why am I going into this so much? Why am I so supportive of him? Well, obviously it's a professor, but it's a one-of-a-kind work of reference, and I think this is where health should begin today. People spend a lot of money on supplements without any research or any idea of what they should be doing, and they get themselves in trouble. Then they go see a doctor, and they're always looking to hack their way in by one little pill, even though it's a supplement, it's a natural supplement. And I'm sorry if it's a little sarcastic there. It's just like, this is where we are today. And here's a person who did 40 years of work, 36 plus what he's been doing recently. And his book is phenomenal. And so this is the link, but what is really interesting is that there's a number of free chapters you can have. You go down and you can download these free chapters. Obviously, this is where you order it. And I believe it's just under $200 now, which you get this book, plus you get a searchable database for the entire book, which you'll find out is pretty handy. Also, I want to show you, here are articles that you can download. Nutritional treatments of opioid addiction. You know, opioid addiction has increased over COVID. That's really appropriate. Is folinic acid beneficial for autism? Probiotic may prevent group B strep in pregnant women. Iron deficiency and congestive heart failure. How appropriate. Which supplement should we use? Folic acid or methylfolate? We talked about that. Comments on Alzheimer's disease and copper. Probiotic prevents dental caries. So it goes on and on. I strongly suggest on the very least you peruse his website, download some free chapters, download some of these articles, and you'll see if you invest in this first before you buy any supplements and get hooked on whoever's brand, why don't you invest a little bit in understanding how to use supplements? You'll probably be far more educated than your doctor would be. And that's how you should be. It's your body. It's up to you how to use it. Okay? Till next time. The link for Dr. Gaby's book will be in the show notes. Take care.